Okay, folks, I think we're ready for our last session. So today I'm really honored that our last speaker is somebody I actually can say is a good friend of mine as well, as a colleague and somebody I've worked with. Jim Harner is the Executive Director of the Daniel Hanley Center for Health Leadership. I say that fondly because myself and at least a few other people in the room are graduates of the Hanley Leadership Program. It's a great program if you ever get the opportunity. Jim is the Executive Director now. He's been there since 2005, and he has worked closely with the Hanley family and other healthcare leaders in establishing the center in 2002. Before joining Hanley, Jim served as 3 years as president of the Maine Health Information Center. Some of us know it as MIC. It's now called OnPoint. Northern New England's primary independent, nonprofit health data research organization. While he was at MIC, Jim served as the initial project director for Health Infonet. And I remember those days well. We survived. So it's my honor to welcome Jim, and I hope you find this last presentation very informational. Thank you, Jim.
Thank you, Ralph, and greetings, everybody. It's a great opportunity for us to be here today to tell you about a very, I think, important statewide initiative that's been underway now for several years to accelerate the adoption of EMR among Maine's behavioral health community and to lay the groundwork for information sharing between behavioral health and medical care providers throughout the state. Many of you in the room just heard my colleague Deb Culver talk about Health Infonet, and we're going to be referring to Health Infonet a lot during my presentation as well. I think you all know that Maine is absolutely a national leader in the establishment of a statewide health exchange, one of the first to go operational, and I believe the largest operational health information exchange in the country today, something we can all be very proud of. I'm here today to tell you that Maine is also staking out a national leadership role in the behavioral health world as well. There's still a great deal more work to be done. It's going to be a years and years long process, but things are really moving, and I'd like to spend a few minutes today bringing up to speed with some of that work as you look over the horizon at what's coming up next and working with behavioral health providers, perhaps more in the future. Before I do that, though, I'd like to just tell you a little bit about my organization and maybe answer a question that might be rolling around your mind. Why is a leadership institute involved with EMR? The Hanley Center is an independent, nonprofit organization that's statewide. We're based in Portland. We've been around for about 10 years. Our mission is to help support the transformation of health and healthcare in Maine and northern New England by working to build a culture of greater collaboration. And we've long had an interest in EMR and electronic information sharing because it's a classic example in our mind of a complex issue that requires a collaborative solution. When we, my board of directors and I, look at how healthcare is delivered in Maine and around the country, what we see is the same thing that you all see, which is dozens and dozens of disconnected silos: the hospital silo, the physician silo, the behavioral health, public health, et cetera, et cetera. And a lot of our work is around leading efforts to bring together diverse stakeholders to tackle complex issues across those silos that require a higher level of collaboration. And this project that I'm about to tell you about falls into that category. What we're best known for, I think, is a couple of leadership programs, one of which Ralph referred to earlier, called our Interdisciplinary Health Leadership Development Program, now about to begin its 7th year. bringing together a wide array of healthcare professionals and clinicians and administrators and others from throughout the state, through a wide swath of professions and settings together to learn new skills in collaborative leadership, the kind of skills that people like you who work across those silos within your organizations and within your communities, new skills at how to engage stakeholders, step above some of the competitive pressures, step above some of the political pressures, and really find common solutions that are in the best interests of the people of Maine. Really pleased that a number of senior IT professionals here in Maine have enrolled in that course. In addition to Ralph, Todd Rogow from Health Infonet who's here today, Danny Burgess from Maine General is a graduate of our program, and others as well. So we do that program. And also, I think you might be interested to know that our newest program is quite interesting as well. It's a statewide initiative to enroll 400 Maine physicians in very substantive executive leadership and management courses over the next 5 years. And our goal is to reach fully 10% of the practicing physicians in Maine, and to help them be more effective leaders and to help bring the clinical voice to the decision-making table around operational decisions and policy decisions. And 18 months after the launch of that program, we're about to enroll our 200th physician in that program. There's an explosive interest right now in Maine and around the country in physician leadership, and there's a recognition that among physicians far and wide now that there's really nothing in their medical training that prepares them to lead teams or to lead in the decision making in a whole lot of issues today. And the physician community is on fire right now, trying to get smart. And through our programs, that's one of the avenues that they're taking. And I can tell you, I travel the state extensively, and in small meetings and large with physicians everywhere, the conversation always comes around to EMR implementation, the challenges, and also how much they value the terrific work of people like you who are making that possible. So I want to applaud you for the terrific work that you do on a daily basis, collaborating within your institutions around some of the most complex technical issues to improve the care that Maine people get. So let's talk about our initiative. And first of all, I'd like to say that we're really at a key milestone today here in Maine. For the first time, there are about 15 behavioral health providers here in Maine, provider organizations that are accessing information about their patients, medical information about their patients that they did not have access to before. This is all developed in recent months through Health Infonet, and it's due in part to some terrific collaborative work that's been underway in Maine over the past couple of years in engaging behavioral health providers and connecting them with medical providers. That's a small number, and there's a long way to go, but that represents a real leadership role for Maine. This ain't happening in other parts of the country at all, and the country's really looking to Maine and a handful of other states to show the way. As Dev said, those of you who were in the previous session said, there's also, Maine has recently been named a recipient of this very large State Innovation Models grant from the federal government, from CMS. And a very important element of that grant is to provide funding to expand behavioral health access to the exchange, and to bring information in and to make more information available. And I believe that I heard Dev say that nearly $2 million will be available over the next 3 years to something like 30 behavioral health providers to help them acquire systems and implement systems and really accelerate the use of information exchange. It's all well and good to talk about having a large operational health information exchange, but until it starts to include information as important as behavioral health information, we can't even come close to really actualizing its promise in terms of improving care. We know, all of us in this room know, that our patients move around from provider to provider. We have providers prescribing medications to their patients without any knowledge that another provider across town or across state may be prescribing something that's contraindicated, just as one example. And behavioral health is huge, a huge part of the healthcare environment here in Maine, and we've got to do more over time to bring them into the system, just like we need to bring other elements of the healthcare system into the exchange in order to really fulfill its promise. This work really began almost 2 years ago when the Maine Health Access Foundation here in Maine awarded the Hanley Center some funding to bring together the behavioral health community here in Maine for the first time to talk about electronic records. And one of the first things that we did was we did a survey of the providers throughout the state. Just getting access to who the providers are in behavioral health was an immense challenge. This is a very complicated, diverse environment. I used to think when I was at the Hospital Association for 15 years in the 80s and the 90s, I used to think that after 15 years of roaming the state and getting really familiar with all the hospitals, that I had a good grasp of healthcare in the state of Maine. I stepped out of that job into another job that brought me in contact with others, and I realized just how little I know and how big and how complex and as siloed as the hospital community is. When you get into behavioral health, it's many, many, many more silos. They're very complicated. Not a big history of collaboration, of coordination of care. Minimal resources to do things. And so we did a survey, just like in the early days of Health Infinite, we did an initial survey to try to understand the current status of EMR implementation, let's say in primary care and hospitals. We did the same thing in the behavioral health community, and we learned that they're using those relatively few providers that were using EMR 2 years ago were using vastly different systems and really weren't prepared at all to share information even between behavioral health providers, much less between behavioral health and medical care providers. That work was allowed to go forward because about a year and a half ago, Maine was the recipient of another very important grant. This time, referred to on the slide there, is in 2012 from the federal government through SAMHSA and HRSA and the National Council of Community Health Providers. Maine was selected as one of 5 states in the country to do some very focused work to accelerate the adoption of EMR and really begin the exchange of information between behavioral health and medical care. And we've done this work over the past year in close parallel with our friends at EMHS and their Beacon project, which is doing great work up in this region, as well as very important initiatives through the Maine Health Access Foundation, Quality Counts, and other organizations that are really working hard to try to better integrate behavioral health and medical care throughout the state. All this talk about meaningful use, behavioral health providers, the vast majority of behavioral health providers do not have access to any of that, have not had any access to meaningful use dollars. And our survey showed then, and a more recent survey showed that hasn't changed. That probably the number one issue for behavioral health providers is they don't have the dollars to bring in EMR to make that very tough transition that you know about, and that's a major barrier. That's why all of us are so excited that this latest funding, the State Innovation Grant, is actually bringing real money here that can be taken out to help 30 behavioral health providers really move the ball forward. So things are limited right now, but they're moving fast, and we're going to see tremendous growth in the next couple of years. The first year that we brought stakeholders together to address this issue resulted in a report that covered a number of recommendations, these 7 recommendations that you see behind me. And I just want to mention a couple of them, and I can answer questions, of course, but this first one around accountable care. Back a year or 2 ago, as these accountable care organizations were taking shape, there was really very little mention about behavioral health at all. We felt then, and we feel even stronger now, that these large ACOs that are taking shape, that are really going to be responsible for population health, cannot fulfill that responsibility, cannot be effective in managing population health unless they have data about behavioral health providers. And so we, part of the idea here was to try to develop a strategy for persuading the emerging ACOs to start looking more closely at behavioral health and ways that they can perhaps even help behavioral health providers within their regions acquire EMR and acquire the systems that allow that information to be shared and then fed up into data repositories where de-identified data can then be made available to better understand the true population health. There were a number of other recommendations too. One that I was particularly close to is around number 4, focus and simplifying data sharing. Just like in medical care, there's a limitless amount of patient-level clinical information that you can put into an exchange, but you got to be careful that you don't put so much information in the exchange that you defeat the purpose for easy 24/7 access for clinicians, sometimes treating patients in emergency situations where they're overwhelmed with data and they can't find the key information that they need. And so we focused on that as an important recommendation, that if we're going to start gathering and sharing behavioral health information, we got to narrow the field to what's really important. And in a few slides later, I'll show you what I mean by that. Also, there needed to be some action taken to really increase funding and incentives for behavioral health providers because they don't have access to meaningful use money. Parenthetically, by the way, there's been a bill floating around Congress the last couple of years that would extend meaningful use-like incentives to the behavioral health community. That didn't go anywhere in the last Congress, unfortunately, but it's my understanding that there's a continued effort to make that happen. I don't know what I know Deb and others from Health Infonet just got back from Washington, and perhaps a little bit later I can ask them what the outlook is on that. It was pretty grim the last we knew. By the way, Senator Snowe, before she resigned, signed on as a sponsor for that bill. There is interest in working with the congressional delegation to try to build their awareness of this issue if there's an opportunity for this legislation to pass later on. More currently, over the past year, using this federal dollars that came in actually to Health Infonet, and Health Infonet hired the Hanley Center to keep the stakeholder engagement process, bringing all a large number of behavioral health providers together to keep it going. And our primary objective is to build the capacity to share information through the statewide exchange. So we narrowed the focus to not just accelerating the adoption of EMR, but what steps we can really take to allow for information sharing to take place. And really pleased that a number of key IT professionals took an active role in this process, like Ralph Johnson and Todd Ruggo and others. And we had strong involvement by Beacon Project and others throughout the state. I mentioned earlier that funding clearly is a big barrier, but also laws governing the sharing of mental health and substance abuse information continue to be both a real and a perceived impediment. HIPAA, as you all know, lays the floor for privacy, but if state rules and regulations are more rigorous than HIPAA, then the state laws rule. And here in Maine, we've had a very big development over the past several years. I think it was 2011, correct me if I'm wrong, someone, but the Maine legislature passed a law that allowed mental health information to come into the health information exchange. And it also specified that mental health information could only be accessed by providers with the consent of patients. So while Health InfoNet is an opt-out system, everybody's medical information goes into the exchange unless patients opt out. Behavioral health information can go into the exchange, but it's opt-in. It's only with the patient's consent. There's a very interesting piece to this that I'll mention in just a few slides about a wrinkle to this that you all need to know about. The federal substance abuse laws are very rigorous and can't be trumped, as I understand it, by state law. And so substance abuse information for the foreseeable future is not going to be accessible in the exchange. This becomes important because so many behavioral health patients have co-occurring conditions. They're not only dealing with behavioral health issues and medical care issues, but a very large percentage of them are also dealing with substance abuse issues. And so you've got providers that in that world treating for substance abuse and for behavioral health that really need to be mindful of medications and et cetera, in order to prevent errors and to improve care. So this focused effort over the past year has really focused on doing more to accelerate this information exchange. And we developed 4 work groups to move this work forward. And several dozen behavioral health providers from throughout Maine have been actively involved in these work groups and steering committee that guided this work. And they fell into those 4 buckets, and I just want to tell you a little bit about each of those. First of all, we've, like in the early days of Health InfoNet, we recognized there was a need to really engage consumers. And we know that there's a lot of angst out there about individual medical information being shared. Interestingly, I don't know, 6, 7 years ago, when we first started to focus groups through Health InfoNet and talk to consumers about their concerns about privacy, they told us that while they were very concerned about the possibility that if information was their information was in an exchange, that it might be inappropriately accessed through a breach or whatever. However, they saw the value of improved coordination of care, and they felt that really trumped their concerns about privacy. And that work led us to really decide that it was critically important to talk to consumers in the behavioral health community as well. And depending on various conditions and diagnoses, that can be a very challenging population to engage in focus groups. And I'm really pleased to say that last summer we were able to convene with a lot of help from the behavioral health community 5 mental health consumer focus groups throughout the state, and to talk about these issues. And it was really interesting, what we learned. And we saw among this focus group participants, some very strong interests. There's a sense that they're getting maybe second-class care because providers can't exchange critical information as much as they should have. This first bullet is particularly interesting. We heard that there's the potential for for Health InfoNet, the exchange, to really act as a surrogate patient voice. What we mean by that is that you've got a patient who's very psychotic, being cared for in an ED. For instance, that patient probably doesn't know all the medications that they're taking on and is in no position to communicate that or communicate it accurately to the provider. So the exchange, the ability for the clinician to access that information becomes absolutely critical, just like it does on the medical care side when an unknown patient arrives at the emergency department. And all these other bullets really are very closely tracked with what we heard from consumers in the early days of Health Infinite. They see the benefits, and they're sick and tired of repeating the same information over and over again and hauling their own information around from provider to provider. So consumers are really starting, we're starting to begin to engage them. And that becomes obviously critically important because this is an opt-in system. And patients got to understand what they're opting in into or opting out of. They do have, despite that, they continue to have concerns. There's still, as you know, a tremendous stigma attached to having a behavioral health diagnosis, and patients are concerned about that. They're worried. In some cases, they don't want their primary care doctor to know that they're being cared for by a behavioral health provider because they feel that there's a stigma attached to that and they may somehow be treated differently. And I think there's some pretty strong evidence that behavioral health patients often are treated differently, so there's a legitimate concern there. This access to HIE is all or nothing is something I referred to earlier. What this means is that when a behavioral health patient opts in, that means that their information, their mental health information, is going to be accessible to providers, as well as their medical care information as well. The downside of that is that if they later opt out, they're in the system, and they later decide to opt out, everything comes out, both their behavioral health and their medical health information is out of the exchange. So if they show up the next week at an emergency department and clinicians are battling to save their life, that their information, none of their information will be in the exchange. Did I get that right, guys? Yeah, good. There was another one of our work groups really started to look ahead, and this is where there's a behavioral health community has so much to learn from your experience on the medical care side in terms of implementing EMR. And this group developed a provider survey, went out to behavioral health providers to learn more about where things stand and what the barriers are and what kind of tools that they need in order to effectively implement EMR when dollars become available, and so we've learned a lot in this process from your experience. Again, the bottom bullet, it's no surprise. Today, just like 2 years ago, and probably 2 years from now, the behavioral health providers are saying we just don't have the dollars to bring this technology in and to implement it. And we've got serious privacy and security concerns. I failed to say that one of the things we did in the first year of this project was we worked to bring in health lawyers from throughout the state to help them understand more about the exchange and this effort, and also to inform them about the new laws that allow mental health information to be into an exchange. And even with that, though, the lawyers around the state, health lawyers who are advising behavioral health providers and advising your organizations, are not unified. There's a lot of interpretation, and there's a lot of concerns that, particularly in some provider organizations, that they could get into trouble if they allow information exchange to go forward. So there's a lot more work, I think, to be done with the legal community as well. But we've made some progress there. In this work group, we also found that the behavioral health provider community is really getting it about EMR. There's clearly strong and growing interest among the behavioral health community, the provider community, to acquire these systems and to be able to exchange information. But there's a need for an immense amount of training and resources to do that. There's within behavioral health provider organizations, there's such a culture of privacy, intense patient privacy, that I think it's going to be a barrier, even more so than the medical side. And there's got to be work that needs to be done to over time to change that culture and to really persuade providers and staff of behavioral health agencies that really this is in the best interest of their patients to be able to share information carefully, very carefully. So there's a lot of work to be done there. I'll just shoot these slides pretty quickly, but I do want you to know that there's some key information on the health information, on the Health InfoNet website in terms of toolkits and other resources that are available to behavioral health providers to help get them going towards EMR implementation and learn from the example of the medical care side. A lot of this, toolkits have been adapted from some very good information that's been available at the national level for some time. This just quickly show you, these are two slides that just show that this work group also started to look at the patient intake process. Okay, if the patients need to opt in order to take advantage of the information exchange, or have their providers take advantage of it, we really need to be thoughtful about that process for as they are brought into the clinical registration process to make a smart decision about whether they want to opt in or not. And one of the distinctions here is that our group is recommending that it's actually a clinician who's talking with the patient rather than a registration person or a reception person about this opt-in, opt-out thing. They think that they feel that that's an important element of the process. And then there's also the client referral and sharing information as patients are referred to other behavioral health providers or medical care providers. This is Todd Rogow and I work pretty closely on this one, this is the issue of kind of winnowing that information down to just what's really needed. And we went through a really interesting process of identifying 5 use cases. When do behavioral health providers need information? What kinds of settings? What kind of time of day? What kind of conditions do they need key information from? And then built a set of recommended data elements of what's really needed, and which is another way of saying what's not needed. But this is what's really seen to be critical. If you're a behavioral health provider, for instance, on a hotline, a suicide hotline at 1 o'clock in the morning, just as for example, this is the kind of information that you need in order to perhaps save that patient's life. This was the worksheet that we did to take these 5 use cases and to try to narrow that field to the data information that's really needed. Finally, we did a good deal of work this past year with a lot of help from organizations around the state to open up communications further with the emerging ACOs to try to build this case that really it would be in their interest to help behavioral health entities, even independent behavioral health entities in their community, to acquire EMR to improve the coordination of care, but to also implement the kinds of EMRs and information sharing systems that can allow the ACO to see to better understand the true population health of their communities. So these are some recommendations, and I think that there's also getting down to that last bullet. This gets back to that federal law that I talked about earlier. Dev, you just got back from Washington. What's the latest on the Behavioral Health Information Technology Act? Can you remember?
Let me a couple of things. I think based on what we're hearing that it's going nowhere.
Going nowhere.
Yeah. but I think there's a larger context there, and that is what we did hear very clearly is a growing concern about meaning police itself. And the congressional delegation in Maine is hearing a lot of chatter. I don't know if you saw the announcement last week about the 6 Republican senators who came forward expressing concerns about whether the meaning police program had in fact demonstrated that it was getting to where it needed to get to. There's a lot of discussion we heard about concerns that there's still about $25 billion left in the meaningful use program and questions about whether or not we should stop and think a little bit more about how to spend that money rather than continuing on to stage 3. So as far as behavioral health goes, it looks pretty dead in the water for now, but I'm just concerned you're also not hearing about the potential that meaningful use itself may take a very hard right-hand turn. If you did not notice, the sequester took 2% out of stage 2 too also. So there's some things going on that front. Sequester won't be the end of the discussion, but there is a very strong concern that we are not on the right path.
So don't go too far away because this is my last slide, and yeah, I do want to say that yeah, there's a lot of work continuing on this, but I want to emphasize that there's a lot of really interesting things that are happening, right now through Health InfoNet. For instance, there are 5 behavioral health organizations that use a common electronic system called ClaimTrack that are getting ready through Health InfoNet to be able to actually exchange information, meaning feed information up to the exchange for the behavioral health patients that opt in, and also to view medical care information about their patients. It's called bidirectional. So that's moving forward and holds great promise. And then something that, and I'll let Dev give you more details on this, but also getting around this issue of behavioral health providers not having the dollars that they need to acquire EMR. There's a plan that's unfolding to make available a secure email system to about 200 providers here in Maine so that they can securely share patient-level information with consent that way without acquiring an EMR. Do you want to say anything more about that?
Well, not really. Basically what Health InfoNet did was stand up an instance of Direct. You know what I'm talking about. Great. If you don't, great. But the fact is that the behavioral health community, for the most part, does not really have an infrastructure in place for secure transport of patient-identified data, and many of them don't have even EMR to run that through and out of. So basically, we're focusing on that community in addition to some other smaller provider structures that don't really have access to a good secure email structure, and making it available both through the grant programs and contract programs, but also, quite frankly, in some instances, some of the CCTs that are coming along too, because they're wanting to experiment with connection out into non-traditional, non-provider structures. We're finding out some of those CCTs involve things like people's minister. Interesting. And they're wanting to have that support structure being secure communication. So more coming on that, but it's not something we're actively promoting on a large scale.
So all this, the end result of this is not just to help accelerate the adoption of EMR and information sharing here in Maine, but to also inform efforts in other states. And so a very comprehensive report of all this stuff has been provided to the national organizations and the federal government. And we think, will again position Maine as a leader in this work and to help other states follow suit over time. So we're at early stages, but some really substantial progress. So I just want to, I want to take some questions here, of course, but I just want to end by saying that I'm not, as probably was evident to all of you in my remarks, I'm not an IT guy myself, not a technical person at all, but I've had the good fortune over the past 10 years to work really closely with a lot of your leadership in the development of Health InfoNet and in this work like this. And I got to tell you how much I admire the important work that you're doing under very difficult circumstances, and recognize that you have to be effective collaborators to do your work. And the Hanley Center admires that, and we want to support you and your profession in any way we can to help you build collaborative skills, and also to work through our new Physician Leadership Institute with the physicians so that they can be more active collaborators on their end as well. And we're going to do more on that in the months and years ahead. So thank you very much. Any questions or comments? And I'm also open to corrections from those of you that may know more about what I've been talking about than I do, that if anything needs to be corrected. Questions? This is the Friday afternoon on a gorgeous day. You notice I arrived late and I didn't give you a weather report because I figured that everybody would be at. Any questions at all, folks? Any clarifications or corrections, Todd, Ralph? Okay, good. Well, thank you very much, everybody.